You are watching The Wellness Hour, the leader in medical news and information. I'm Randy Alvarez. Today's topic, narcolepsy. You may have it, according to my first guess, and you don't even know it. If you're sleepy during the day, you could literally fall asleep during the day and have a tough time sleeping at night. You may have this. And there are things, good news, that you can do to turn this around. With us, we have an expert on the topic, Dr. Dasgupta.
Thank you very much, Randy, for having me here. And narcolepsy.
Was I wrong? Was I okay on some of the things that I was saying?
I love the introduction. It got me excited to talk about it. And I just want to say narcolepsy is underdiagnosed.
You love this topic, we should mention.
It is. You know, I am a sleep medicine doctor, and when one of my passions in sleep medicine is correctly diagnosing narcolepsy. I always feel it goes under the radar because everyone always assumes it's going to present in its typical way, and it doesn't all the time.
So when people think of it, like from the movies, it's somebody that could be talking and then they fall asleep.
You just kind of named the classic stereotype. Head, here's a cereal bowl, right in there. That's more than what narcolepsy is. And let me just go back to definitions.
Okay.
Narcolepsy is a chronic sleep disorder where your sleep-wake cycle is dysregulated. Normally, we have non-REM sleep. You go into the 3 stages, N1, N2, and 3. Then 90 minutes later, you'll have your first REM sleep. Why is REM important? What happens in REM sleep? Most of us will have very vivid dreams, but you lose muscle tone. You lose muscle tone. And my narcoleptics...
So too much REM sleep is not good?
Too much of anything is not good.
Okay,
but in my narcoleptics, when they fall asleep, they go into REM right away, and that's where the problem begins. Losing the muscle tone, the visual hallucinations, the episodes of paralysis that they may get. And that's defining how we will make that diagnosis
I know a
correctly.
person that's like this.
Yes.
And they blame it on... They say, well, Randy, I don't sleep at night. That's why I can fall asleep so easily during the day.
Right.
So couldn't it be just because of that? Because they're not sleeping at night?
And like with any disease, any disorder, sleep or not, you have to take it with the history and the physical. If someone told me that, hey, I have a 20-year-old in college or I have a 16-year-old in high school and they're falling asleep, I want to make sure they're getting enough sleep every night. I'm not going to say, hey, number 1 diagnosis is narcolepsy, but narcolepsy itself has 3 main ways it presents. Number 1, excessive daytime sleepiness. What does that mean, Randy? Is that, you know, there's a difference between the word tired and sleepy. I didn't get a lot of sleep last night. You know what? I'm very tired today. But
so somebody's at work and they say, you know what? If I wasn't at work, I could sleep right now.
Sleep, not just they're tired.
They
could
literally
actually fall asleep. So that's the excessive daytime sleepiness. That's the number 1 symptom that brings them to see me. Then I ask about the other symptoms. And the funny thing is, and it's not really funny, that we assume that because they have narcolepsy that they're going to be sleeping like that at night. Oh, time to go to bed. But it's not. What do we say about their sleep-wake cycle? It's dysregulated. Frequent wakenings at night. And that's a problem. Then the last thing that everyone talks about in movies is these accessory symptoms, the cataplexy, which is when they have intense emotions like laughter, anger, suddenly they faint.
So that happens?
That's cataplexy. And it does happen, but I wanted to mention it doesn't always have to be like the movies. It can be very subtle. I make you laugh, I make you angry, I make you cry. You could have weakness of the arm, buckling of the knees, drooping of the face, slurring of the speech, and if you don't look for it, you don't ask for it, you'll miss it. And that's why I wanted to bring
And this is common, really?
So, you know, common is a broad word. And when we talk about the incidence and prevalence of narcolepsy, it's underestimated grossly because people don't believe the diagnosis, are not looking for the diagnosis, or not seeing sleep specialists.
Okay.
Yeah.
And so what can you do about it? What are the medications?
Well, first off,
what are their side effects?
I'll give them the right diagnosis, and that's the most important thing.
Okay.
And narcolepsy is diagnosed based upon the history, but unfortunately, how many people say, hey, you know what, doctor, I have these classic cataplexy, I have the classic symptoms? A very small portion. So you have to look for them. We do a sleep study, because you know what? If you have sleep apnea, I'm not going to treat you for narcolepsy. You may have an overlap, but I'm going to treat the sleep apnea first. Okay. So I do the sleep study to make sure they at least get 6 hours of sleep at night. And then during the day, right after the sleep study, I do a study called an MSLT, Multiple Sleep Latency Test. Simply put, these patients are like, you know what, doctor, if you weren't here right now, I'd fall asleep. I'm like, prove it. So during the day, they have 2-hour opportunities to nap after a full night of sleep.
And they're wearing something?
They have their wires that are monitoring their brain waves, their respiratory and everything, so I know what stage of sleep they're in. So after a full night's sleep, you should not sleep at all during these naps. If they fall asleep within 8 minutes, that's a positive test. Their sleep latency is too short. And then I see when they fall asleep, I find out they fall asleep into REM. If they fall asleep into REM sleep at least 2 times in the study, and they sleep short, a sleep latency of less than 8 minutes, that's a diagnosis of narcolepsy.
Okay.
So we'll establish
And these
that
are
first.
people, I think you told me in my green room that
Yeah.
they have a tough time holding a job.
Oh my God. Right now, I'm working at USC. I'm having a lot of undergraduates, a lot of students. I'm so happy to take care of them. And you know what? They're not doing well in school, and these are smart people.
Is it on the rise?
Yes, it is. I think that there's many foundations out there. I did an episode on the doctors about this. It's a really big passion for me, and I think that as we let them know that it's not as rare as you think, and we may not are misdiagnosing it, unfortunately.
As what, depression?
You nailed it on the head. Depression,
ADD?
Anxiety, ADD, and especially in our
Interesting.
younger individuals, And I think this is where only when you take care of these patients and when you treat them appropriately and they come back to you and say, you know what, I got to that graduate program. I'm not getting yelled at by my parents anymore. I'm keeping my job. It makes you happy. It really does.
Okay, so what are some of the medications, the medical treatments then?
So once again,
And how soon could they get better?
you know what? Quality of life almost instantaneously. But a couple caveats to that. When you have narcolepsy and we treat the symptoms, the 3 symptoms are going to be, number 1, the excessive sleepiness. We have medications for that. The poor sleep at night and the accessory symptoms. So let's focus on one of those right now.
Okay.
Excessive sleepiness. What do we treat them with? Number 1, we'll do napping. I know it's not kind of oh, what a great answer, but I encourage napping in narcoleptics. They will actually feel more refreshed. But if it's not doing it after our sleep hygiene, we use stimulant therapies. Traditional medications go by the names of Ritalin, Concerta, Adderall, but we have neurostimulant medications such as Provigil and Nuvigil that help them keep awake during the day. But let me say something that,
Okay.
you know what, just because I gave you Ritalin or Provigil, you're not going to be like, I don't feel sleepy anymore. They will unfortunately always feel sleepy, but they can function during the day.
So these aren't the kind of stimulants like caffeine.
They're similar to
So these are-
caffeine. They're similar to caffeine.
Okay.
Caffeine is a stimulant in itself, and that's what these are. So with any medication...
So what in the brain is it stimulating then to
Well,
produce more of that keeps
it's
them awake?
keeping you alert. These are all alerting type medications. When we talk about narcolepsy, the main physiology, I'm glad we're talking about this, is a neurotransmitter named hypocretin. And this hypocretin is something that's supposed to keep you alert. But in narcoleptics, the classic narcoleptics with cataplexy, they're depleted of it. And
Interesting.
let me give you a little pearl. Let me give you a little what's going on in society here.
Okay.
Is that, did you know that narcolepsy is associated with autoimmunity, meaning that certain infections like strep throat
Can trigger it?
can cause it.
Can cause it.
And influenza A. And did you know in Europe there are vaccines that were given that they did their job. They formed antibodies against these horrible viruses, but it also formed antibodies against that neurotransmitter hypocretin. So there is
That keeps you alert.
that keeps you alert. And if
Is
you
there
don't-
a simple test somebody could take for this to measure your neurotransmitter?
I wish there was.
There isn't.
But unfortunately, if you're going to measure it, I would have to take a needle and put it in your spinal cord and measure that spinal fluid, which we do not do commonly.
So you can't do it.
Can't is a strong
So
word.
you have to use the medication that stimulates that, and then if that works,
And
then
it's
you
not
know
the
that's an
medication
issue?
that stimulates it. These medications are
Okay.
broad stimulants that
right.
will keep you alert during the day to function well. Now we're only talking about the excessive daytime sleepiness. Napping, medications, watch their side effects, but once that they have these accessory symptoms, what if they have the cataplexy? So what I say is the problem with their sleep cycle, they have the REM sleep. What happens in REM? They lose the muscle tone. So I use medications that block REM sleep so they
Interesting.
won't have these cataplexy symptoms, the sleep paralysis, the visual hallucinations when falling
So you were
asleep.
telling me somebody that's falling asleep, they get paralysis.
Yeah.
Like they can't move their body.
So you know what? Sleep paralysis in itself can be seen in normal individuals. People who are just tired, sleep deprived, can
Okay.
have paralysis. The key thing about it is they'll get their paralysis when they're transitioning into the sleep, not when they're waking up into sleep. Because what did we say? Narcolepsy is a disease when you're falling asleep, your sleep cycle gets dysregulated. And we could do that by giving certain medications such as antidepressants, which their innate properties of the drug is to block the REM sleep.
Now, when you're giving stimulants, do you have to keep upping the dose over time? I mean, if somebody has this
Right.
problem,
Right.
their brain isn't producing this neurotransmitter,
Mm-hmm.
are you upping it?
So every narcoleptic patient is an individual. there's not one set regimen where you're like, here you go on your merry way. You have to spend time, you have to talk about when you give the med, how do you give the med, and there are some patients that, you could give just a bare minimal dose and they do great. Some patients don't need medications. They could just do scheduled napping and they do great. But yes, I think we were joking about this earlier, is that in some patients, what's better than 5 milligrams of Ritalin? 10. What's better than 10? 20. And we could go on all day. And that's where the art of medicine, I could use that terminology, kicks in, that side effects and benefits and what other options are out there.
What's the biggest mistake when treating this, maybe with the wrong diagnosis? By goodwill or good intentioned primary care physicians?
I think that when someone comes in and they're excessively sleepy, I do believe in my heart that, hey, common things are common. Get a sleep diary, get a sleep schedule. Maybe they just need a little bit more sleep. Maybe they have sleep apnea,
but a
which
sleep
is
study,
one cause.
they have to go in one of these places and being monitored, or there's at-home sleep studies?
Well, when we're talking about narcolepsy,
Okay.
it's going to be an in-house sleep study. But you're right. When we talk about sleep apnea, home sleep studying is a huge topic we could talk about another time. But this is something where it's done in an inpatient setting. We want to monitor their stages of sleep, monitor other symptoms that may be contributing to their excessive sleepiness, and we do the napping study in-house during the day.
Okay. And the kids, talking to parents for a second, what are the main symptoms of your kids?
So one thing I do personally is I always invite my parents. When I have younger patients, sometimes they're older, but I invite the parents to come in there because sometimes it's hard to swallow that my son or daughter has narcolepsy and they were misdiagnosed or undiagnosed. And common things that we mentioned already is attention deficit disorder. Common things are going to be depression, anxiety. And what happens is they are placed on antidepressants that partially treats some of the symptoms of narcolepsy, and it makes it even more difficult to diagnose. And it prolongs the diagnosis. So when you hear the stories of these patients long term, it's heartfelt. It's tough.
Now you're out of USC. Are
Yes.
you seeing one a month that's being diagnosed?
You know what? I think my partners, USC is doing a great job of getting the message out there. We are having people being evaluated frequently for excessive daytime sleepiness. And I would say at least once or twice a month, I'm making this diagnosis of narcolepsy.
Interesting.
Yes.
And like anything else, like you mentioned with the other things, when it's treated correctly, they get their lives back.
And sometimes in some patients, just by giving a diagnosis, puts a smile on their face, which always puts a smile on my face. We sit down, and it's not a treatment. It's like, here's one pill, and you're
So
gone.
they feel like, I'm not just depressed, I have this problem?
Yeah, and it sometimes gives them that peace of mind. And I see a lot of positive outcomes when you take the time to be with your patients, put them on the right medications, they're happy. And what more can you ask for?
Okay, great.
Yeah.
So if you have these, and most of this is being managed by the primary care physician, if you or a loved one has these type of symptoms, ask to speak to a sleep specialist.
And
what do you ask? Who should you see?
I would say that 9 times out of 10, it's usually a sleep specialist taking care of narcolepsy. It is a very specific diagnosis. I think that if you have excessive daytime sleepiness, you feel you have these symptoms of cataplexy, the sleep paralysis, maybe you should tell your primary care that take it up a notch. Maybe a sleep doctor would be a good way to evaluate us, but we would probably continue with that, their maintenance medications and their maintenance therapy.
All right, good. I want to thank you for coming on the show.
Thank you again.
Pleasure having you on the program. You've been watching The Wellness Hour. I'm Randy Alvarez. I wish you good health.